association with this city and a very close association with this city. So let me first talk about those associations and then we talk about the subject. This is my birthplace. So I was born here and I did my pre-medical schooling from here. And I have a lot of school friends, which are, some of them are very prominent. And I did my MD in 1980. And the first job I joined was in Nazareth Hospital in 1980, where I worked with very senior physician, you might be knowing, Dr. T.B. Singh. And when he was there, I could get blessings from some of the stalwarts of the cities. Dr. B.L. Agarwal, Dr. V.N. Mittal, Dr. D.K. Nigam, Dr. Samant, Dr. Stalekar. So I was really blessed and to see that I had learned a lot of things. Then I joined CGHS. And in CGHS, I worked in civil lines and bank board dispensaries. And there I met Dr. D.K. Nigam. So it was a very close association. And to top it all, I was married in this place. I'm really pleased to have my brother-in-law, Dr. T.N. Vyas, who is an ophthalmologist here. So really, I'm very pleased to be here. And the second thing which I want to add is that I think after Cochin, IMA, I think this is the best IMA hall I have seen. So a lot of thanks and a lot of blessings to this place for having such a beautiful hall and auditorium. So that is about my close association with Allahabad. Now let me talk about the topic, why I choose advances in neurology. Because in the last few decades, a lot of changes have taken place in neurology, in the field of neurology. And I chose three main common topics in neurology. One was headache, epilepsy, and stroke. And what I wish that in all these three fields, the advances which have taken place should percolate down, not only from the metros, but should percolate down to all the cities. And I wish this comes to Allahabad also. It's such a prominent and great city that we have. So let me first start it. So first start with headache.
तो मस्ती कर रहे थे आज दिन भर में
Just 1 minute.
Okay.
We all get headache, isn't it? And headache can be just a routine affair, or it may be a very sinister, life-threatening symptom. And so we always divide headache into basic two types. One is a primary headache, and the other one is secondary headache. Now, the primary headaches are those headaches where the person gets headache, but we cannot prove or show any abnormalities on any examination. And in secondary headache, we can show abnormalities when by any pathological test or by any means. Fortunately, primary, secondary headaches which are more dangerous, they are rare. They account for only 10% of the headache. And the most 90% of the headaches are primary headaches, where we do not find abnormalities. But these persons, they suffer a lot, and there is a lot of disturbance in their quality of life, and we must give them proper treatment. And we have seen many patients who are having headache for a long time, they have primary headache, and they go from one specialty to another specialty without making a diagnosis. The common secondary headaches are caused by subarachnoid hemorrhage, meningitis, glaucoma, brain tumor, and the clinical pictures are different. But the primary headaches, they are more common, and the most common ones are migraine. The second one is what we call TAC, or trigeminal autonomic aplasia, and the third one is tension headache. Out of these, tension headaches are the most common one, but I will be talking mainly about migraine because we see a lot of patients where the diagnosis is missed in migraine. Before that, there are some clinical red flags which can differentiate between the primary and secondary headaches, and they are grouped together as what we call SNOOP. S stands for systemic symptoms with the patient has a headache with a fever, weight loss, or any risk factor like HIV or cancer. If there is a neurological symptom associated with it or abnormal signs are there, like confusion, impaired alertness or consciousness. If the onset is sudden, abrupt or progressively worsening, if the onset is progressive and it occurs in a person beyond 50 years of age, we must be very, very cautious. Or if there is a previous headache history, first headache, or a headache which is different, which is changes nature, then we must be very clear. And a triggered headache by either Valsalva or Exerton. So this is a mnemonic which can be used to differentiate between a secondary and primary. Because secondary headaches are, though they are rare, but they are very dangerous and they must be immediately taken care of. So we'll be talking briefly about migraine and what are the advances which have taken place in the field of migraine. Migraine is the sixth most disabling disease in the world. And it is so common that 1 in every 10 persons suffer from migraine. It is 3 times more common in females. In fact, 40% of the female population, they suffer from migraine. And migraine is a very characteristic clinical picture, which I'll just elaborate. Usually, when a person gets in a migraine, there is a prodrome of 24 to 48 hours. And a person feels just change in the mood or change in the appetite or is irritable, depressed. And then in 10% of patients on migraine, there is an aura, which may be visual or tactile, which lasts for about 60 minutes as maximum, which is followed by headache. Now, headache has a very characteristic, most of the time it may be hemigrania, but not necessarily. It may be bilateral, it may be some other part, and it is associated with nausea, vomiting, photophobia, phonophobia, and osmophobia, so smell, and the person feels very bad. What is worst is that during these headaches, the person is not able to do the work, and he may be any activity increases it. So that is a classical type of migraine which occurs. And this headache lasts for about 4 to 72 hours. And this is followed by a post-drome. When again the person may be exhausted, tired, he may lose his appetite, he may be irritable. So then it becomes normal. But this is the classical picture. Not necessarily all these patients, they have this kind of picture. So there's a lot of variation in the symptomatology. And therefore, a very simple thing to diagnose migraine is just 3 basic questions which can be very useful. One is that did you ever feel any headache in the last 3 months having any of one of these features? Did you feel nausea when you had a headache? Did the light trouble you when much more than when there is no headache? Or did the headache ever limit your ability to work, study, or do something when a person not able to do his work? So if any one of them is positive, there is a very high index of suspicion the patients are migraine. And fortunately, since in these patients there is no abnormality in clinicals or in pathology or in radiology or investigation wise, so there is a very objective clinical criteria which has been followed very easily by everybody, which has been laid by International Council of Headache Disorders. And they just say that you can label a patient of migraine if the person has more than 5 attacks, which lasting for more than 4 to 72 hours. And if it has more than any 2 or more than 2 of these criteria: unilateral location, pulsating quality, moderate or severe intensity, aggravation by causing avoidance of routine physical activity. So if 2 of these criteria are met, or one of them, nausea, vomiting, photophobia, phonophobia. So if 5 attacks are there, then you can label the person as a patient of migraine, and then we should treat the patient accordingly. So this is about migraine. As I said, in 10% of the patients, they are preceded by aura, which may be visual, maybe some flashes of light or fortification figures and or babies lights may be seen. There may be sensory phenomena in the form of tingling in one part of the body or so. There may be disturbance of speech, language, motor, brainstem, retina. So, but they are rare. But if they are there, then the diagnosis becomes much easier. What is unfortunate is that if we don't treat these patients who have episodic migraine, they go into chronic migraine. And once they go into chronic migraine, the headache becomes very severe and then it lasts for more than 15 days in a month. So you can imagine how bad the condition of the patient is. So if the patient is chronic migraine, what is worse is that the chronic migraine is very difficult to treat. That is one. And secondly, the commonest cause of migraine, chronic migraine, is medication overuse. So these are the two things. So the person gets headache, he takes painkiller, and then it gets worsened, and then it gets perpetuated. So chronic migraine is very difficult. So there are therapies which are there mainly for the abortive treatment, which can be given during that attack to abort the attack, or given during the to prevent it. Now, preventive attacks are given in those persons when the person is getting recurrent attacks, say 4 to 5 times a month. So if person is getting more frequent attacks, or if he feels that the headache is disturbing his or making his life difficult, then we can try a preventive treatment. And there are three levels of preventive treatments are available in the, which has been classified with the American Association of Neurologists. The first group says that these are the first level A group, which includes anticonvulsants like sodium sulfate, clopiramate, antihypertensives like propanol, metoprolol. The second, which are probably effective, they are amitriptyline, venlafaxine, atenolol. And the third one, which are possibly effective. So there are a lot of drugs which are there. And what is interesting is all these drugs are not really anti-migraine drugs. They are really antihypertensive, antidepressant, or anticonvulsants. And they give relief only 50% of the patients. So we do not have any specific treatment for migraine still. And the reason for this is because we do not know the exact pathophysiology of migraine. There's a lot of controversy, but now the present consensus is that it is a neurovascular phenomenon where somehow the trigeminal vascular system, the trigeminal system gets activated. Now, this trigeminal system, once it gets activated, it is modulated by a compound which is known as calcitonin gene-related peptide. Now, this is present in several parts of the brain, but is also present on the blood vessels of the cerebral blood vessels. And once these trigeminal nuclei, they get stimulated by any means, they act through this CGRP on these CGRP receptors which are present on the blood vessels. Now, these CGRP, they initiate an inflammatory reaction, and that is how the person gets migraine. So this is the latest theory. And now we have certain drugs which are acting on CGRP receptors. So probably now what is the advance in migraine treatment is that we have a treatment which can be given for this condition, which is specifically for migraine. There are several points which support this theory. That it is a potent vasodilator, which is the cause of headache in most of these patients. It increases when you stimulate trigeminal ganglia. It increases during migraine and cluster headache. It is blocked by sumatriptan, which is a drug which is about headache. And the systemic infusion of CGRP triggers migraine and cluster headache only in those patients who suffer from migraine. And it increases intracranial levels in chronic migraine. And once they treat, the level falls. So something like a Cox postulate. So probably we are making a headway where we can find a specific treatment for migraine. So that is the advance. Now, this can be as an abortive treatment as well as for the preventive treatment. Unfortunately, the drugs which are used for abortive treatments, they are very highly toxic. So they are not being marketed right now. Some of them may be marketed soon. But for prevention of migraine, we have these monoclonal antibodies, which 4 of them have been approved by FDA, and 1 of them is available in India. The first 3, they act on the CGRP directly, and the last one blocks the CGRP receptor. This is marketed by Novartis, Arunibep. It is the first targeted migraine prophylactic treatment in India. It inhibits CGRP signaling by binding CGRP, It comes in two strengths, 70 microgram and 140 microgram. They are given subcutaneously and over the thigh, stomach, and the upper arm. They are given monthly. 3 injections are given, and they are said to prevent the migraine in majority of the patients. The only drawback with this is that it is expensive. Each injection costs 25,000 rupees. But the advantage is that it is not, since it is a monoclonal antibody, it is not metabolized in the body, through the liver or the kidney. So it does not have any side effects. We have used in fact, now 10 patients we have given this. I won't say that the response is dramatic or perfect, but in some of the patients, there's a dramatic relief, some get a partial relief, but they get relief. The only side effect is constipation. So that's what
काम नहीं करवाया तुमको कहे थे
this migraine should not be.
दिखाई वो नहीं दिया तुमको
उसको देखो
कैसा पहन के आता है कैसा
Coming to the second part, epilepsy.
समझदार दिखेगा ना झाड़ू
Again, epilepsy is very, very common.
हाँ नजर
About
रखो
10
जैसे
million
दिखे
people
तो वह
in
तो उठ ही
India
जाते
suffer
हो
from epilepsy. That is about almost 1% prevalence.
और इतना भी आएगा पहले इसके पास
20%
पहले
of
तो नहीं
the
आने वाला है वो पकड़ में आ जाएगा
full
पकड़ लो बस
epileptics, they reside in
सवाल
our, India. 70 to 80% of them can be treated, and unfortunately, even among them, more than 50 to 70% are receiving no treatment. So there is a treatment gap, despite being a common condition, and despite having all the treatment which are available to us. So this is very unfortunate. So there is a medical treatment gap which should not be there. There is a lot of hurdles, social stigmas around them. The recent classification of these epileptic seizures can be basically focal, or it may be generalized, or it may be unknown. And they can be because of several reasons which are labeled here, maybe structural, genetic, infectious, metabolic, immune, and unknown. And then if we are comfortable to classify, there are a lot of epileptics. I'm not going these details. What is more important is many of the epileptics, they have a lot of comorbidities in social, psychological form, which also should be taken into account when we are treating them. Till 1990, there were only 5-6 drugs.
अरे यार इस
Most of drugs which have been into the market. This is very confusing. This confuses a person. Now, when we have a lot of drugs, it means that we are not able to get a suitable drug. So the new drugs have a lot of advantages, but very expensive. We have limited exposure to them. They have come very recently. So we should try to rationalize our treatment. I will not go into detail, but what I am trying to show the advances which have been made. So despite the newer drugs which are there, the control rate is more or less same. Still, we are not 30% of them. There was a very good article which appeared in the New England Journal of Medicine, where they showed that if you use one drug, about 47% of the patients can be controlled, half of them. If you use the second drug, another 13% will be able to. So that means about 60% of the patients or epileptics can be controlled by 2 drugs. But beyond that, only 4% increment is there. That means if somebody is using more than 2 drugs in a person of epilepsy, that means you are not treating a condition properly, and we need to go further. And that will be my point of highlight. So 30% of new epileptics have poor control of seizure, and majority of them are focal epilepsy. And half of these patients have some brain lesion on neuroimaging. So these people, so if you see 10 million, out of that 30%, that is about 3 million have focal epilepsy, or 50%, that means 15 lakh population have a focal seen
शादी भी इसके अलावा पहले का काम करते थे
and there are 2 conditions
85 के बीच में
commonly seen in this.
85
One is what we call visual temporal sclerosis,
CGHS की क्लिनिक डिस्पेंसरी में भी काम किया है
and both can be surgically treated with a very good result. So all these patients who have a poor seizure control with more than 2 drugs, they should be subjected to intensive workup to exclude a surgically remediable cause. Unfortunately, there is a big surgical treatment gap exists in our India. As I said, 15 lakh persons need surgery. And you know how many persons are getting surgery in India? Only 800. So there's a big treatment gap, and we should make all efforts to provide this treatment to these persons because their life is really difficult. And if you treat them properly, give them epileptic surgical treatment, they can be given a lot of relief. So there are definitions how to make a diagnosis of refractory epilepsy. As I said, the simple formula is
दवा कहाँ
not
खरीदें?
able to
दवा तो
control with
मंगा
more
लें,
than 2 drugs,
माँ
that
को
means
बोल
you are
देंगे.
getting a refractory epilepsy. But what is more important is that in a studies which have been which we do in a refractory epilepsy, 30% of patients they are non-epileptic and they are labeled as epileptic. So this is our experience. So this should not be cut. So when we make a diagnosis of epilepsy, our effort should be make a proper diagnosis, and it must be documented that the person has really epilepsy. So once we get a patient who has this kind of seizure, refractory epilepsy, we usually organize some sort of epilepsy conference where we take the help of neurologists, neurosurgeon, neuroradiologists, psychologists, and the social workers to make a team effort to see whether the person is really eligible for surgery or no. And we, based on our investigation, which are history, physical examination, video EEG, MRI, PET scan, and neuropsychological evaluation, we can get a patient where we can delineate a focal abnormalities which can be surgically resectable. And if it is in a place where there is, which is non-eloquent, like a non-dominant hemisphere, that can be taken care of. If it is in a place which is located, but it is in an eloquent area, like motor area or speech area, where if we take it out, then the person will have neurological deficit. Then we try to really do what we call a diagnostic surgery to point out this place. And if these are not surgical, then we can do a medications or corpusculotomy and all those things. So, yeah.
I think we've completed many minutes of your talk.
Uh,
But you can.
I'll just take 5 minutes now. Okay? So very quickly. So I just want to highlight this about something about mesial temporal sclerosis. We should know very clearly that a person who has mesial temporal sclerosis presents with a history of febrile seizure, and then there's a period of quiescence for 5 to 10 years. Following that, the person gets attacks which are focal types of seizure, where there is a person gets an epigastric aura, or they have a memory disturbances because it's the mesial temporal part of the brain is affected. And all these patients can be subjected to surgery, and a very simple investigation like MRI can delineate hippocampal sclerosis, and this can be taken care of. So this is just showing you an area of hippocampal sclerosis, and this can be taken off. This can be dissected. This can be shown on EEG. There are some EEG abnormalities, and this has been taken out in the patient, and the person becomes seizure free. As I was telling that if you are not able to delineate, we can put an electrode inside the brain, and we can do that. We are doing all these things at our Medanta hospital. So the clinical protocols are mesial temporal sclerosis. It can be easily recognized with proper clinical history and investigation. Surgery is a potential cure, and it is important to consider surgical option in all patients. But in just 2 minutes, I'll talk about stroke. The advances in stroke. I don't want to say that stroke is such a common condition, but what I want to highlight that stroke patients should be immediately offered a treatment within 24 hours. This is very, very important. And I just know that 85% of stroke are caused by blockage of the blood vessels, 25% are large vessel atherosclerosis, 20% are small vessel atherosclerosis, 20% are cardioembolic, and the rest are undetermined. These patients who have large vessel atherosclerosis or small vessel atherosclerosis, if they come within 4.5 hours, they must be given immediate thrombolysis treatment. Unfortunately, despite it being available since 1995, it is not being given even in most of the places. So I emphasize stroke is such a condition which is treatable. Ischemic stroke must be given priority by giving a thrombolytic treatment within 4.5 hours. If it has been given, if the person comes beyond that, we can offer treatment beyond that. And now there is a advance in the such a place. Like what we are doing is now that we can show the place, we can delineate by neuroimaging, advanced neuroimaging, the area where there is an infarction and where there is a polyemia. And we can salvage that tissue by doing what we call it diffusion perfusion imaging. And this can be available in most of the places, but thrombolysis, I want to emphasize all these patients of ischemic stroke, if they come to us, we must thrombolize them within 4.5 hours. I just remember one of the patients, he was traveling from, he was a police officer, was being posted to Tripura at Allahabad railway station. He developed a stroke. He came to one of the hospital and then he was sent to us. He could have been given thrombolysis. I appeal to you to provide this treatment into all the patients because it is a very effective treatment. So thank you very much. This is the flow chart for the stroke patient. It comes within 4.5 hours. We can give thrombolysis. If it comes 6 hours, we can do thrombectomy. We can go up to 24 hours. We can do a thrombolytic treatment here and transfer the patient to a tertiary care centers. But the thrombolysis must be given at our place. Thank you.